Everybody, my name is Olivia Snyder. I am a third year medical student at the University of Iowa Carver College of Medicine. I've done these almost for like a year now, so you might have seen me in another couple of them before if you've been here. If not, then welcome. If it's your first time, we have a lot of fun and do a lot of interesting learning about medicine. So thank you for coming, everyone. It really means a lot to me, and I hope that we're able to get something out of it today. Our topic is going to be an anesthesiology topic because I'm actually interested in doing anesthesia. So I wanted to bring a little bit of my personal interest into virtual rounds. And today we're going to talk about epidurals, specifically labor and delivery epidurals, since a lot of you guys have said in feedback on past virtual round sessions that you're interested in OBGYN. So this is going to be kind of a collab between the two. So we're going to start off by going through a patient case, and that will include a physical exam and our differential diagnosis, which for this is not really a pathologic case. It's more of like a procedural case. So there's not much of a differential, but we'll go through a couple different like pain management options more so, an assessment and plan, and then lesson on the not so much pathology, but more of like the anatomy and physiology and pharmacology of epidurals, and then wrap up from there. So hopefully you're all able to access the SOAP note and quiz. It is optional. You don't have to do the quiz, but if you'd like to get a certificate of completion, then you can fill that out. It's supposed to be very low stakes. If you want to go back at all to any of the slides to help with the quiz taking, or if you are confused and we're moving at a pace that's not good for you, then please stop me and we can go back, slow down, speed up, whatever works, okay? And I also love when you guys participate. So if you're comfortable unmuting yourself to ask questions or to answer questions, then please feel free. And if not, then using the chat is totally fine as well. So this is what the note looks like. And just jumping right into our case. We have a 27-year-old G2P1 female. And before we go any further than that, I just want to tell you guys, this is the notation in labor and delivery to explain basically how many pregnancies a woman has had. I go into a little bit more depth with this in a previous virtual round session about preeclampsia, but because it's not really relevant for the epidural part of this case, I didn't want to overwhelm you guys with information. But essentially what this is saying is that this is her second pregnancy and she has one prior child. So the G2, that stands for gravida. 2, that means she's had 2 pregnancies, and her P1, para, means how many living children. So she has 1 existing child pregnant with her second child. And she is at 40 weeks and 1 day gestation, which is full term. And she's coming into labor and delivery triage with signs of labor. So imagine you're staffing labor and delivery and you have this woman come in with, she's 40 weeks pregnant and she sounds like she is having signs of labor. So what are some things that we'd like to ask her when we're getting her checked in?
How far apart are the contractions, and what time is her last contraction?
Absolutely. Yeah, that can be a really strong indicator if she's truly in active labor or if this is more of like a false labor or like Braxton Hicks type contractions. Anything else you guys want to ask her? Her birth plan, absolutely. Yeah, that's really important to know, especially on the anesthesia side of things. Things that we'll be able to discuss with her for pain control. If she is planning to do like an unmedicated or a natural birth versus wanting to have some pain control medically or with other types of mechanisms that we can offer. So that's really important as well. So, kind of encapsulating what you guys were saying before, she first noticed contractions that began 6 hours ago. They've been about 5 minutes apart and lasting for 30 seconds, and she thinks that her water might have broken about 45 minutes ago. This pregnancy has not had any complications, and she's received all prenatal care, which is great. So that doesn't really raise any red flags for us at this point. So the OB team does an exam, and she is 6 centimeters dilated. So we decide to admit her. Her baby is going to come soon, and we are planning for a vaginal delivery. So that is part of her birth plan and also just kind of the default that we have for almost all mothers when they come through, unless they have sort of a special circumstance. So the OBGYN team checks her in and we go to meet the patient. Since as the anesthesia team, we're not really the ones managing her labor process, but we still are really involved in we want to make sure that we meet all of the patients who get checked into the labor and delivery unit. So here are the things that we want to make sure we talk to her about before we go into the room. Her plan for pain control, like I mentioned, some patients do have the preference of doing like a natural or unmedicated birth. Others would like to utilize techniques like massage therapy, a whirlpool bath, deep breathing techniques, maybe like things like aromatherapy, music, distraction, things like that to help them be able to better tolerate the pain without using invasive or medical interventions. We do want to ask her though if she'd like to get epidural anesthesia and go over the risks and benefits for those, because a lot of patients are unsure of what that process looks like, and that can factor into their decision of whether they'd like to pursue that or not. So we go over the risks and benefits, go over the procedure, and we also, hopefully not, but in case we do have to take her back for a C-section, we want to go over what that plan would look like and make sure that we have all of the information, like her past medical history, comorbidities, past anesthesia type things like that, that would help us have information that might be vital later on if that were to occur. So those are the things that we'd like to talk to her about before we go and have our conversation. So we do find out that her past medical history is significant for GERD, or gastroesophageal reflux disease, which is essentially just heartburn. That's really just been in pregnancy for her. It's not really a problem that she has chronically. She also had scoliosis in childhood. So for those of you, if you don't know, scoliosis is a abnormal curvature of the spine, and that can be corrected with surgery. Her only medication right now is a prenatal vitamin, so she doesn't take any other medications. For her surgical history, she did have that spinal fusion surgery at age 11 to correct the scoliosis. And with the surgery, we noticed that, or she reports that she had a post-operative nausea and vomiting. So that's really a common side effect. Almost 30% actually of all surgical patients will experience nausea or vomiting after they come out of anesthesia. But that's been her only anesthesia reaction / complication, and no other serious ones. For her family history, her father does have a history of coronary artery disease, and her mother has hypertension, but she has no family history of anesthesia reactions or complications. For a little bit of social history, this is great just for establishing like a bond and getting kind of rapport with a patient, but also good to have, for other things as well. She works as a pharmacist in a national retail chain. She does have one biological and one adopted child, and she does marathons. So this can tell us maybe that she's in pretty good cardiovascular fitness. And then review of systems is really important in anesthesia because that's what we use to determine people's overall cardiovascular fitness, as well as their history of any breathing problems, GI problems, neurologic problems that maybe aren't as apparent to us just by talking to them or by doing an exam, but that we can get by taking a thorough history and a thorough review of systems. So one of the things that we like to ask patients is if they're able to do activities like walking upstairs, tolerating moderate exercise, that sort of stuff. And that can be really good to assess their cardiovascular fitness. So as we know, this patient does marathons, so she's like in extraordinary cardiovascular fitness. But when you see the older people, 70s, 80s, who are maybe really obese or they're maybe not very mobile, then that can be maybe a red flag that they're not in as good of cardiovascular fitness. And the picture that I attached here on this slide is, please do not memorize this at all. It's not for that reason. It's just to show you guys some of the parameters that go into assessing and quantifying someone's cardiovascular risk during an operation. So there's algorithms and calculations that you can do, but a quick and dirty way is we just ask people like, hey, can you walk a couple blocks or can you walk upstairs without getting out of breath or without having chest pain? And that usually is a pretty good sign. We also ask people if they have any history of obstructive sleep apnea or asthma, trouble breathing. And if you guys had to guess, why do we want to know about like if they have something like obstructive sleep apnea, where when they're laying flat in bed, they have, you know, some tissues like collapsing that cause either snoring or them to stop breathing at nighttime? Why would that maybe matter?
That would matter because that would be an issue since they're being given anesthesia. They'll likely fall asleep and stop breathing.
Absolutely,
And
yes.
yeah,
So when people are asleep, they lose their ability to protect their airway, and being flat like that can also predispose people with a lot of like fat or adipose tissue around their neck, or if they have other anatomic abnormalities of the airway, that can make it both difficult for them to just get like normal air like through a mask, but then also potentially make it difficult to intubate them. So that's a really important and great observation that you made. Additionally, we do want to also ask about their dental history. It seems a little bit weird, like why would we care? But we ask if people have loose or missing teeth, or chipped or cracked teeth or anything like abnormal in the mouth, because again, that does make a difference in intubation. We use a blade called a laryngoscope, which is like I don't really know how to explain it, but it's like a little lever that you use to open up the mouth and then to project a light into their vocal cords. And it's made of metal. So we want to take really good care to not put too much pressure or any have like sudden jerking movements in the mouth, because we don't want to like obviously knock loose any of their teeth or chip their teeth. So it can be potentially of greater concern if people already have those types of issues. And then the last thing we like to usually ask is if they have any personal or family history of bleeding disorders, or if they're on any anticoagulation drugs, because we obviously want to make sure that if they're being cut open for surgery, that they don't bleed excessively and more than they otherwise would. And if we need to give any types of medications or reversal agents for other meds that they could be on to help prevent excessive bleeding. But just for our patient, her review of systems was like totally negative. So that's what you can put in your note. I just wanted to kind of go through these things with you because that's really standard for every surgical patient. Every patient that we evaluate, we ask them basically the same set of questions. So getting to our physical exam, this is where we're going to start the objective portion of the note. We always start with looking at someone's vitals. So starting with her blood pressure, we see that it's 116/78, so that looks perfect. Her heart rate is 64, respirations are 14 per minute. Temperature is 37.0 Celsius, and she's satting or has an oxygen saturation of 99%. So all of these vitals are looking awesome. Her BMI is 26, which is technically above 25, which is the cutoff for like, quote, being overweight, but she is pregnant. She's 9 months pregnant. So, and she's a marathoner. So we can assume that she is not like a very obese person. And so for our physical examination, we do a very focused exam, focusing on like the head and neck area is probably the most like relevant to anesthesia. So the picture that I have attached here is showing what we call the Malampati score. And this is essentially a way of classifying someone's airway and can sometimes predict if it's going to be difficult to intubate them or not based on the visibility we have of their palate. So over here, like the very far left, class 1, if you open up your mouth and stick out your tongue and you can see the uvula and you can see like the back of your throat and your soft palate, I don't know if you guys can see, but like I would be a Malampati 1, and that is essentially like a normal, healthy person. We would produce, or we would probably anticipate no issues with intubation in this type of a patient. On the other side, a class 4 would be someone who has a lot of obstruction in their airway. If they stick out their tongue and it's completely blocking the uvula and the soft palate, and we can only visualize the hard palate, then that can be a poor prognostic factor for intubation. So our patient is a Malampati class 1, which means we can hopefully anticipate if we had to intubate her, which again, we're planning on doing a vaginal delivery, we would not have any special considerations for that. And then the rest of her exam is fairly unremarkable. We do see that she has a well-healed midline incision on her back from the T10 to L2 spinal levels from her previous fusion surgery. And that could potentially be a consideration during an epidural if we're going to give her that, because when I go through the anatomy later, it's kind of in the same vicinity of where we're going to be actually doing the procedure, but this is not going to be directly in our way. It's just something that I wanted to make note of. So essentially, her physical exam is very normal, aside from this past surgical scar. And with any of these details, we can always go back and potentially, like if you guys needed to copy any of this information on your note, or if you needed it for the quiz later on, then please let me know if you ever need to go back. So Des is asking what would cause her to need to be intubated, and that's an excellent question. Like I said, as of right now, our plan is to do a natural or vaginal delivery, which does not require intubation. But as a very precautionary measure, in case she had to go back for like a crash C-section and we have like literally no time to give her like a spinal block to allow her to be awake during the C-section, then we would have to use general anesthesia and use an endotracheal tube or make her intubated so that she can go through that surgery with general anesthesia. So that's not the plan, is to have her do that, but it is something that we always evaluate for just in case, so we don't have to scramble at the last minute and do these things. Okay, so Des is saying that you've had 2 naturals and they never looked in your mouth. That's yeah. So maybe institution dependent. But at the place where I've been training at the University of Iowa, they treat every patient as if they were going to have to do like kind of the worst case scenario in terms of the like evaluation beforehand. But then as soon as we like get that initial information, then we of course tailor the rest of their hospital stay to like what they individually need. So yeah, thanks for sharing your experience. So this is our assessment and plan. We have a 27-year-old female with a history of GERD and scoliosis who is status post spinal fusion. Just kind of a little background information about her in the one-liner to start off the assessment. And she's presenting in labor and desiring epidural anesthesia. So she has a remote history of postoperative nausea and vomiting, that's what PONV stands for, after general anesthesia for her spinal fusion. She has no personal or family history of anesthesia reactions, no history of cardiac, respiratory, or coagulation disorders, and we have no airway concerns, and she is a low aspiration risk. With that risk factor being that she has that little bit of the gastroesophageal reflux or the GERD. So overall, this is a very reassuring assessment. The plan for this patient is just going to be to do a very standard epidural block based on her own request. And because of her history of a spinal fusion, we might have to use an ultrasound to help identify the correct location within her vertebrae to do the procedure. But we can also try without that at first if we, see that it's able to be done just based on exam. If a C-section is indicated, then we will plan to use the existing catheter for a bolus dose of the Neuraxial anesthetic. And I'm going to go through all this in the next couple of slides. So if you have questions, I would too, if I was you, just hang tight with me. And then if general anesthesia was needed, we would ensure that we have proper antiemetics, which is anti-nausea medicine on board, because we know she's in the past had nausea and vomiting after general. So again, the plan is not to give her a C-section. The plan is not to give her general anesthesia. These are just worst case scenarios at this point. Okay, before I move on, I just wanted to check in with you guys, see how we're doing. Do you have any questions about this patient's history or about the plan that we have for her right now?
Okay. So I was wondering, besides doing the ultrasound, does the fact that this patient had a vertebral fusion surgery in the past impact like how the location of the epidural will be found or how it's inserted?
Yeah, that's a great question. So
Okay.
if I go back quick, I don't even remember what I put in her exam. So she had a T10 through L2 spinal fusion. And when I'll show kind of the landmarks of the vertebral anatomy that we use for epidurals, but where we actually shoot is going to be either L3, L4, or L4, L5. So that's going to be below where she had her fusion. In some patients, if you're not lucky and it happens to be in the same location, then essentially all the difference that you'd have to do is make sure that you use that ultrasound machine because their anatomy might be a little bit distorted and they can't produce that nice curvature of the spine when you bend over to help like open up the vertebrae and space them out a little bit better because they're all fused. So really the only difference is using that ultrasound to help identify where your landmarks are going to be. But in this patient, it looks like it's going to be out of our way. But that's a great question.
Thank you so much.
Mm-hmm. Okay, so now we're going to get into kind of the second half of things. I mentioned earlier this thing called neuraxial anesthesia. So what the heck is that? There's actually two different types of neuraxial anesthesia. The one that you've probably all heard of before is the epidural anesthesia. But there's a second type called spinal anesthesia, and they're extremely, extremely similar. There's just like one difference anatomically. So, epidural anesthesia is a mechanism of pain control where the drug is going to be delivered continuously through a catheter, like a really, really tiny, like spaghetti noodle straw with a hole through it that delivers it into a space called the epidural space. And I'll go through a picture of the anatomy in a couple slides. But it's basically, this is the space that is surrounding the outside of the spinal cord. It doesn't enter the outer layer of the meninges. So it's just literally sitting on the outside, kind of like the peel of an orange or the peel of a banana. Um, and it also tends to take longer to set up because it's farther away from the main nerves in the spinal cord. And it can also sometimes be lighter in the quality of the block so that you can still feel some of the contractions and maybe some some motor function preserved in your legs. It doesn't necessarily mean that you can like get up and walk around. Like they don't usually have people do that, but compared to the spinal, it is a little bit lighter. Now the spinal anesthesia, like I said, they're very similar in what they look like and what they do. But the spinal is going to enter what's called the spinal space or the subarachnoid space. So it's going to be in continuous flow with the cerebrospinal fluid, and it actually crosses in through the outer layer of the meninges and is in direct contact with like the fluid that bathes the spinal cord. So it's a one-time bolus. We only give like one injection worth of medication that just stays there and nothing is left behind. And then it's also a much stronger and faster block compared to epidural. So they usually reserve this for patients who are not actively in labor, but maybe they have a planned C-section so that they have that strong block for their surgery. And like I said, it basically just like takes out all of your pain sensation, all of your motor function within your lower extremities. And like you just can't move for at least for the few hours that it's working in your spinal cord. So I know that can probably maybe seem like nuanced and confusing, and I'm a visual person, so we'll get to some diagrams here in a second. But first, I wanted to show you guys where this actually is going to be taking place. So like I mentioned, we're going to be shooting for the L4 to L5 interspace. If we look at a diagram of the spine here, it kind of lines up with the very top of the hip bones, and that's called the iliac crest. And that's approximately where we see the L4 vertebrae at. So that's going to be our landmark. If you see, like if a patient's sitting in front of you, you kind of put your hands on the sides of their hips and you feel for where that hip bone is. And then you can use your thumbs to feel for like where the nearest vertebrae is to that line. So that's kind of a cool anatomy correlation. And then I hope that this is not too confusing for you guys, but I really wanted to emphasize like where the drug is actually going. So for the epidural anesthesia, I have that in this sort of red color coded box here. So you can see that the dura or the lining or the meninges around the spinal cord, it's kind of sitting like a layer above it. And the actual drug is going to sit in this tiny space outside of the dura mater. Whereas the spinal is going to cross the dura mater, it's going to actually puncture that, and it's going to go into this spinal or this subarachnoid space. And all this fluid here, like all these nerve roots and the actual spinal cord, are going to be in direct contact with it. So it's literally just the matter of going one more step past that membrane and getting it, in closer contact with the nerves. So I think we have a couple questions here. Adam is asking, does the epidural impact just the afferent pathways of the spinal cord or both the afferent and the efferent? So let's first define what afferent and efferent are, if you guys don't know, and I always mix these up. But afferent is the ones that are returning from the extremities up to the cord. So that's going to be like the sensory information that comes back to the CNS. The efferent are going to be the descending or the outgoing signals from your CNS to things like muscles. And so it is nonspecific, so you do affect both the afferent and the efferent, which means you're going to have both sensory block and motor block. So your legs, or the muscles of your legs, it kind of turns to dead weight. So like when we're positioning a patient for a C-section, if they've had an epidural or if they've had a spinal block, then we kind of have to have two or three people move their legs because they just can't move them. So that's a great question. It is nonspecific, so it will affect both. And then Gavin was asking, do both the epidural and spinal go into the L4 and L5? That is an excellent question. And they do. Let me go here. Sorry.
This is Dr.
So I'll go back to that video in a second, but basically the procedure itself is exactly the same. We start both off by palpating the landmarks. We feel the iliac crest and we palpate for the L3, L4 or the L4, L5. Basically, we're always going to start at L4 and it's just a matter of if it's easier to get above or below. So we're going to go through the same exact space, use the same exact landmarks. We're going to make sure that it's a nice sterile space. We use a sterile drape and sterile gloves and sterile dressings and clean and disinfect the area with an iodine to make sure that there is as little risk for infection as possible. And then we also, for both of them, are going to give a little shot of lidocaine to help numb the skin, because as you can imagine, the epidural and the spinal needle is pretty big. If you saw this and you were like, oh my gosh, that's going to go into my back, that can really freak patients out, and it obviously can be painful. So it helps to give a little tiny dose of lidocaine just to help with the numbing of the skin before we give the big shot. And then this is where it kind of splits off. So for an epidural, we use a needle that has a soft catheter around it because we're going to end up threading that into the epidural space to give that continuous infusion. And we're going to stop before we cross the dura mater. We withdraw the needle and we leave the catheter, and that's for the epidural. And then for the spinal, we actually do puncture the dura mater and we inject the medicine into the spinal space, and then we remove the needle and there's no catheter left behind. So that's the difference between the two, but the beginning first couple of steps are exactly the same for both of them. Let me see what other questions we've got up here. Oh, I think you're, okay. Yeah, you're welcome. Okay, so I'm gonna go back to this video to show you guys kind of Where did I say I was going to start at like 155 to kind of show you guys like what
This
it
is
looks
Dr.
like.
Cal Shipley with a review.
And you don't have to really like listen to it, like the details. I just want to see you guys like the actual space.
In an obstetrical epidural anesthetic. A long needle known as a TUI needle is first advanced into the soft tissues between the spinous processes of the fourth and fifth lumbar vertebra. A syringe containing a few cc's of saline is attached to the TUI needle.
And don't worry about the saline thing. That's a little bit beyond the scope of this conversation.
The needle and syringe are advanced steadily through the interspace. Once the tip of the needle is advanced into the epidural space, the operator notes a release of the syringe plunger as the saline squirts into the space. The epidural catheter is then inserted through the TUI needle. Owing to a slight curve at the tip of the TUI needle, the catheter is directed upward, approximately 4 to 5 centimeters into the epidural space.
So again, we're not crossing into the actual spinal cord here. And there's a cross section for you to see as well. It's going on the outside of it for the epidural.
The TUI needle is then removed. To ensure that the catheter is properly placed in the epidural space and not within the dura and arachnoid coverings, a syringe containing a small dose of anesthetic, typically lidocaine, is attached to the catheter and injected.
So again, then you can see it's kind of encasing it around and not going to like the inside of it. So that's essentially the procedural part. I hope that was maybe a little bit helpful to visualize. I didn't have a like comparison for a spinal, but essentially, again, you just be going like a couple of millimeters past that and then just giving that injection and not leaving the catheter behind. Gavin's also asking if these procedures are ultrasound guided to be able to see where the needle is. And sometimes they are, but a lot of the times you don't have to. You can do it based all on feel. And that's, one of the many procedures that anesthesiologists are trained very rigorously in to make sure that they know exactly like what the anatomy is and where they are within these different regions. And sometimes in what we call like harder sticks, people with either abnormal anatomy or if they've had like these spinal fusions and surgical procedures that may make it more difficult, or maybe they have a larger body habitus and they have more like fat or adipose tissue around their back, which makes like finding the landmarks more difficult, then you can always have ultrasound as a resource to help with the placement. But I would say I've actually seen more that do not require ultrasound and are done all based on feel. Okay, so we'll keep going. If you guys, again, have any questions about the difference between the two, then we can always go back and please feel free to ask. I did also want to talk about the pharmacology of local anesthetics. Like how do they even work, right? So anything that ends in the suffix caine, C-I-A-C-A-I-N-E, for example, lidocaine, novocaine, bupivacaine, these are all local anesthetics that have the mechanism of being a sodium channel blocker. So if you guys have taken like any certain neuroscience or maybe even psych or biology, hopefully you've seen this graph of an action potential, which is propagated by nerves to transmit electrical information. And in the action potential, we start off with a really low concentration of sodium inside of the cell. And then when an action potential occurs, you get a bunch of influx of sodium inside the cell. And then we repolarize and re-equibrate the electrolytes and the ions that cause this action potential. So by being a sodium channel blocker, you're effectively blocking it from getting over this threshold of sodium influx and stopping the nerve from propagating the impulse of pain that gets sent to your brain and is perceived as pain. So that's the mechanism of these local anesthetics. And there are some, some side effects or toxicity because a lot of things in your body use sodium channels, including your cardiovascular system and other important parts of like your brain and your CNS. So it is rare, but sometimes if we have a local anesthetic toxicity, meaning we either give too much of the medication or we inject it into the incorrect space. So if you hit like a blood vessel instead of being in the epidural space and you get it circulating throughout your body, then you can have things like dizziness, vasodilation, which is where your blood vessels like open up really wide and your blood pressure goes down and you get hypotension. And then very, very rarely, but it can happen, would be like cardiac arrhythmias, which would require like a shock to help correct that back. Again, these are very, very rare events, and we take excellent care to make sure that the medication is dosed appropriately and given in the correct space. But those are the signs that we want to look out for in potential toxicity. Okay, so continuing on with our case, our patient does tolerate the epidural placement well, and she's very comfortable. However, a few hours later, her baby starts showing signs of distress. And despite close observation, the OB team makes the decision to perform a C-section delivery. So what adjustments would we want to make to her epidural for pain control? And what kind of like vital signs or things would we want to be monitoring during her surgery? She's kind of just already gotten, again, this sort of like low level continuous amount of medication that is still allowing her some sensation and function, but just kind of blunting it. So how would we want to change that for a C-section? Yeah, we're just going to give more. We could also do a spinal. Yeah. So doing a spinal, again, we would have to go back and re-inject because we'd have to get that needle into the further space. So we could go back and do a spinal. That would take, maybe 5 to 20 minutes, depending on like how her anatomy is. Or we could also just bolus her epidural, because we have this catheter, we can control how much is going in, right? So we can kind of crank up and give a bolus of her epidural anesthetic to help give her a more complete block and better coverage for her surgery. So during a C-section, almost all of them, the patients are going to be awake, and we drape a curtain so that their head and neck area is physically separated from the rest of the surgical field, like down where they're actually operating. So some things that we are going to be watching closely in all surgeries, regardless of if it's C-section, if it's asleep, if it's just conscious sedation, we always are going to watch for these 4 things, regardless of what's being done. And that's their blood pressure, their heart rate, their oxygen saturation, and their temperature. Those are like the 4 non-negotiable things that we always are going to monitor for if we are providing anesthesia care to someone. Optionally, you can also measure their level of paralysis. That's a little bit more important in things like being like if they're completely asleep and sometimes can have some like random jerking movements, but we don't give like a full body paralytic to someone who's awake because that's just not how it works. So while, this patient is awake and she's having the surgery, we are able to talk to her and see how she's feeling and see, are you feeling nauseous? Are you having any pain? How are you doing emotionally with all of this? Is there anything we can do to help you feel more comfortable? Those types of things. So it's actually a great privilege to be an anesthesia provider during these types of surgeries because it's such an amazing life event that you're witnessing and helping this patient through. So again, like I said, medication adjustments, we're going to give her a bolus dose of that bupivacaine for better pain control. And we're also going to make sure that she's on IV fluids for blood pressure support and anti-nausea medication because she has a history of feeling nauseous. So let's see, what else do I have here? Wait, before we move on, do we have any questions about kind of that transition from a vaginal delivery to C-section? And I know this isn't like an OBGYN virtual rounds, but if you had like a question about that, I can attempt to answer it, but I just wanted to make sure that we are doing okay. Okay. And if not, like I said, we can always go back. So quick patient update. It's a boy. Yay, congratulations. Our patient did tolerate the C-section well, and there were no complications. Like I said, sometimes in one of the side effects of a local anesthetic, and this doesn't have to be like a toxicity level, but just it actually is very common for patients to get hypotension because of the vasodilation that happens. That's actually one of the first side effects that people notice is the hypotension. So to combat that, we give her a drug called phenylephrine. And this is going to help combat that vasodilation by constricting the blood vessels and helping to bring that blood pressure back up. And it's super, super common for them to give phenylephrine after these patients get a bolus dose of the anesthetic to go into a C-section. Like I'd say more patients than not require the phenylephrine. So after her C-section is over, we discontinue the epidural. It does take a couple of hours to wear off, however, so we just kind of monitor and make sure that she's regaining function appropriately, but then also still making sure that her pain is controlled because a C-section is still a major abdominal surgery and we want to make sure that she's not in a ton of pain post-operatively, especially with a newborn to care for. So mom and baby are both doing well in postpartum recovery. So yay, happy ending. That's the end of the case. I did want to talk a little bit about anesthesiology. Like I mentioned, that's one of the things that I'm interested in. And a couple virtual rounds back, somebody had requested like a pathways slide, which I thought was like the best idea ever. So I've been trying to include a little bit about the specialty that we talk about. And so anesthesia is a really cool, awesome field where you get to do a lot of hands-on and procedural type things like intubations, IV placements or arterial line placements, regional nerve blocks, epidurals, and spinal blocks, like what we talked about today. And it's also a super broad knowledge base. So you're using things that you learn even from like the very beginning of med school, like physiology and pharmacology and anatomy, that, some specialties, they focus a lot more on like the pathology and treatments of disease. So this is a super integrative specialty. It's also a lot of shift-based work. So because you don't have like total ownership over your patients, it's really easy to have people kind of like sub in and out for you during surgeries. So it gives people a pretty nice lifestyle and good quality of life around the work that they're doing. And then if you love the OR, if you love working with patients before, during, and after surgery, then anesthesia might be a really great option for you. So what it takes to get there is 4 years of med school, which is going to be either an MD or a DO in the United States. And then anesthesiology is a 4-year residency. So usually that's one kind of like intern year, prelim or transitional year, and then 3 years specifically of anesthesiology specialty training. So to get to that point makes you a board certified anesthesiologist. And then you can do fellowship afterwards to kind of further subspecialize. And that would be some options like pediatrics, if you like to only work with kids, cardiothoracic, which would have some really interesting like physiology of the cardiovascular system, OB anesthesia, like what I mentioned, like with the whole thing that we've been talking about today. You can only work, like you can designate your work to be with pregnant and laboring patients. Chronic pain medicine. So if you also like to do clinic and have like more longitudinal patient interactions and have like follow up with people, then you can do chronic pain. And then lastly, another major work setting for anesthesiologists is actually in the ICU, where they're managing people's ventilators and sedation while they're intubated and helping to care for them during like really critical sick periods of their life. So that's a little bit about anesthesia. And then as a bonus, I had to throw this in because I feel like everybody, or at least a couple people after every virtual rounds requests something with OBGYN. So a little bit about OBGYN. So obviously you care for primarily women, people with uteruses in all stages of life. You can provide primary care, which would be things like preventative screenings, pap smears, breast exams, and then also the obstetric side of things, like helping patients conceive and go through pregnancy, delivery, and postpartum. You also get to be a surgeon, so you can perform things like C-sections, hysterectomies, gender affirming procedures, tubal ligations, things like that. So you really are like the jack of all trades, except you're exclusively working with like women / females. So this is again going to be, everyone has to go through med school. It is a 4-year residency in OBGYN. So similar length of training to anesthesia, and then fellowships for OBGYN could be things like gynecologic oncology. So treating patients with things like ovarian or uterine or cervical cancers. You can do reproductive endocrinology, so helping people go through things like IVF, maternal fetal medicine, which is high risk OB, urogynecology, kind of working with like the urinary tract and how that is, relevant in a gynecologic setting. And then you can also do things like pelvic reconstruction or female plastic surgery, gender affirming procedures, things like that. So let me see. There's another question from Adam. Do local anesthetics block EPSPs completely, or could EPSPs still continue to fluctuate without hitting an action potential? And that's a really good question. So again, I think that it depends on the dosage that you have. So you can have a like blunted pain response where if it's a lighter dose, then you're still able to have some sensation. There's still some neurologic impulses that are transmitted, but they're just not as intense as they would be. And if you have a really high dose, or if you do something like a spinal block, then it is like a pretty complete block without hitting that action potential. So I think that's the knowledge that I have on it, and anything further beyond that or more specific is going to be more of like a question for a pharmacist because I truly don't know. But I can attest that people respond based on the dose that we give them, and can have varying levels of function and sensation. Okay, these are my sources. And pretty much we're done from here. If you guys wanted to take a minute to fill out the quiz, I'm happy to go back to any of the slides or to answer any questions that you have. I know we're done like 10 minutes early, so I'm happy to stay here and chat about any questions you have about med school or about anesthesia or anything from the case. Otherwise, I will let you guys all go, and I hope you have a great rest of your night. Yes, you're welcome. I love doing these, and I'm really happy you guys participated. And again, happy to answer any questions about applying to med school, going to med school, pre-med type like activities, or even if you just want to vent about stuff. But yeah, I hope I see you guys all again soon. I do have a couple more on the books for the next couple of months. So if there's any topics that you guys want to learn about, please put them in the feedback section of the form, and I'd be happy to try to pick a topic that you might be interested in. That's like literally how I choose all of the topics, except this is the one that I like semi-selfishly picked for myself. So yeah, thank you guys again. Radiology, that's a great one. I think there might actually be a radiology one, but I'll see, and if not, then I can do one. I'll just kind of stay on here until there's not really anybody left. So yeah, feel free to log off, and if you'd like to stick around and chat, then I'll just be hanging out here. And if you need me to go back to any of the slides at all, then I'm happy to do that as well. So Seema's asking, do you have any recommendations for things to do / prepare before starting med school? I think that, I don't know if this is a popular and an unpopular answer, but if you've been accepted to medical school and you're looking for things to do before you start, in the sense that you've already gotten in, then the best thing that you can do to prepare yourself is to relax and have fun. So if you like are trying to study before, or like get a head up on what other people are doing, I absolutely do not recommend trying to study for medical school before it starts. I think it's way more valuable to prioritize your like mental health and well-being, and try to just really get yourself ready and take advantage of the time that you have before to travel or to be with family or friends, or learn a new hobby or skill or something, and just really make the most of the time you have. That being said, if you're asking for recommendations to prepare for medical school, like from either an academic or a, I don't know, just lifestyle perspective, I think that like making sure you have all your supplies that you need. So if that requires that you buy like a new laptop or an iPad or something, then to make sure that you've either budgeted for or have started to work on that process. And I can go back to the Mal and Potty thing. Just let me go back here really quick. Here's this. So yeah, getting your supplies ready, maybe like just developing healthy skills to have, like maybe if you want to learn how to meal prep or get your sleep schedule kind of like on a good routine. Those types of things that'll just make your lifestyle and your transition easier, I think are also worth spending some time on. But again, I do not recommend like studying or doing anything academically to prepare yourself. I hope that's the question you were asking. And if you have gotten accepted to med school, then congratulations. Yeah, Des is saying mapped and Dr. Gray's resources. I couldn't agree more. I've seen a lot of people who really like that kind of stuff, and there's so much content out there. You could probably read like for days about all the different things you can do to prepare. But really, it's just like everyone has a different journey, and you just kind of have to do what feels best to you and what you feel is sustainable and to help you get through the next 4 years. Great question. What other questions do you guys have? Any other slides we need to go back to? Yeah, go ahead, Gavin. I don't care. I have all night. When will the YouTube video be up? Usually it's within a couple of days. I'd say probably by the end of the week that this will be posted. Usually Becca's pretty good about it. I don't personally post it. Could there be a pediatric anesthesiology? I would love nothing more because I love peds and I love anesthesia. I will say, like, as a general principle, a lot of the things are going to be the same. The evaluation is going to be very similar. There's obviously some different physiology in kids, and it changes throughout like the first literally 20 years of life. It changes dramatically from birth until adulthood. So those are like the main differences, but we could maybe go through like some common surgical cases and like the scenarios, different ages and things like that you'd have to take into consideration. But in all honesty, like this physical exam and the history that we take and everything, it's literally the same thing, except usually if the kid isn't able to talk, we like talk to the parents instead. That's a great suggestion. Thank you. Again, I'm probably going to hang out here because like I said, I do have all night. I don't want to keep you guys, so feel free to log off if you're done. But I'll just be available for any other slides we need to go back to or any other questions. So Seema's asking, is being an anesthesiologist kind of routine? Like, is there much variation between patients and how you treat them? So I think it really depends on like your preferences of practice. If you work at like a private practice that does like plastic surgery and you have like a very standard like 9-to-5 job and you just kind of see the same cases over and over again, then it is going to be extremely routine. Some people like to have that kind of structure and to know exactly like what their day is going to look like. And other types of anesthesiologists, like if you're in more of a community hospital, For example, here in Iowa, not in Iowa City, but in Des Moines, which is our capital, their anesthesiologists take call for the entire hospital. So they work with adults and they work with kids. They can take OB call, they can work in the ICU. So it really has a ton of variety. And in terms of the actual operative cases that you do, I think it does vary, like, especially if you're doing a really like complex, high risk case, like, or surgery that this patient has a lot of comorbid conditions. Maybe they're like on blood thinners and they have like a heart, arrhythmia, or they've got like breathing problems and things like that, then it can be extremely challenging to manage all of those things. And I wouldn't say that anesthesia is ever boring, because there's always like things that you have to be like paying attention to. But at the same time, like, you can make it more predictable and just kind of tailor it to what your personal interests are. But in general, all anesthesia, you're going to have very high impact interactions with your patients, because you have such a short time from when you meet them to when you're, putting them asleep for surgery, and you want them to trust you and to understand, everything that you've talked about, and feel calm and ready to go into whatever it is that they're getting done. So it is extremely rewarding to have those interactions with patients and be a part of these really life-changing procedures and events in their life. You get all sorts of people who are like either really anxious and like have never done this before, and like you really kind of have to connect with them emotionally and help them process. And then some people who just like don't care, and it's just kind of like business as usual. So you do have a lot of like interpersonal interactions as well. And I think people kind of forget about that, but it is a super high impact, high value interaction and relationship that you have with your patients. And that's why I think it's really cool, because you kind of get all like the fun, but then like I said, it's also a very like, it's a very subbable specialty. So like, because, after a surgery, you don't have to go and write the operative note and then round on all your patients that you did surgery on for that day, because they're technically not your primary, like you're not their primary doctor, which can be a downside for some people. But if you are the type of person who wants to be able to like, you finished your surgeries at 3 p.m. and you want to go home to your family and not have any like obligations after you're home from work, then this might be like a really good lifestyle for you. And let me see what else you said here. You said one of the prior sessions that I was interested in surgery. Yes. So that's true. I'm still between the two of them. I've been stuck between peds, surgery, and anesthesia for like the longest time. And so part of it is because I love the OR. I love everything that happens in the OR. And I find myself on both sides. Like, if I'm scrubbed into surgery, I kind of look longingly over at the anesthesiologist, like sitting down and like playing the Wordle. And I'm like, wow, that looks really comfortable. And then if I'm on anesthesia, then I look at the cool stuff that's happening on surgery and I'm like, oh, that's just like, they're doing the coolest thing over there. So I think it does kind of come down to the people that you work with, the people that you connect with, the patients that you want to, or the kind of patient relationship that you want to have, and then the lifestyle, honestly, because I also, hope to have a family, and family is one of the most important things to me. And I just got off of a general surgery rotation where I did have to stay late some days and miss family dinners or family events. And that's really hard. And it's something that I definitely have to consider going forward. So yeah, it is definitely, they have some similarities for sure, but they also, you kind of just have to experience both in order to really understand the differences. So Des was saying for scheduled surgeries, they say you can't eat before anesthesia because you could aspirate. How does that change the emergent cases that come in? Does the risk of aspiration need to be acknowledged? That's a very excellent question. That's a huge principle in anesthesia. So that is true. We recommend that people not eat for at least 8 hours before they have surgery. And even clear liquids like a sip of water with your morning medicines, we want to make sure is at least 2 hours before your surgery. If it's an emergent surgery, like a trauma comes in, like somebody was on their way home from Chili's and they got in a car accident, then that doesn't mean that we're like not going to do it. There is actually something called a rapid sequence intubation, which is essentially, so maybe I could do like a typical induction talk of anesthesia, like induction of anesthesia before surgery, because that's kind of like where all the action happens. But once you bring the patient into the OR, one of the things you do is called pre-oxygenate them. And you're actually like pumping with a bag air into their airway. Sometimes that air can also get into their esophagus and their stomach, and then that air can like increase their risk of vomiting, and vomit equals aspiration. So in rapid sequence intubation, we do not do the bag. We do not like actually squeeze air into their lungs. We just go straight to the intubation. You can also do something called cricoid pressure. So if you feel on your neck, there's your thyroid cartilage, which is like your Adam's apple. And then the one below that is called the cricoid. And that's a complete ring of cartilage around your trachea, and cartilage is non-compressible. So if you push on the cricoid, and your trachea is sitting in front of your esophagus, which runs behind it, then you can actually, to a certain degree, compress the esophagus to prevent the contents from coming up and getting into your airway. So that's another technique that we can do during rapid sequence intubation to help prevent aspiration. Can I go back to the section regarding side effects and postoperative nausea and vomiting? Yes. So let's see. For postoperative nausea and vomiting, I don't even remember when I slide that was on. Side effects of the local anesthesia here. So you can have dizziness, low blood pressure / hypotension, and arrhythmias. For postoperative nausea and vomiting, I don't think I really had like a designated slide for it, but essentially it's just a very common reaction that sometimes as high as like 30% of all surgical patients can have when they come out of general anesthesia. And it's essentially just like for the next couple of hours or even like the day after, they can feel really nauseous and throw up. So the treatment for that is basically just we give them anti-nausea medicine. Things like Zofran or Reglan are some of the names of the drugs that we give. And it really just depends on the patient and their preference or how they respond to those agents, because everyone does respond to medications a little bit differently. Some people like Zofran, which is the kind of first line that we use, it doesn't work for them, so we have to try something else. And we want to make sure that we keep them in the hospital as long as they need to still make sure that they're keeping down fluids and that their symptoms are controlled. And that's kind of the treatment for postoperative nausea and vomiting. I know I probably didn't like say that in super extreme detail because like our patient didn't have that, but we do want to make sure that we're providing adequate antiemetic medication for those patients. I hope I didn't miss anybody's question, since my chat box is really small and my scroller is not very good at like keeping me up to date with them. So if I missed your question, I apologize. Please just let me know if you had one, and if not, yeah, thank you guys for coming. I'm really happy that we had a great turnout, and I hope that you guys enjoyed this. If there's anything that you ever need or any questions that you have, you can always email at MotivateMD, and I'm happy to help out however we can. Like this YouTube video will be posted hopefully by the end of the week. And if there's any further questions or topics that you'd like to hear about or any suggestions, then just please put them in the form so that we can make it a great experience for you next time. So if there's not any other questions, oh, here. So Gavin, should we take a dental history? Yeah, I think like you don't have to ask as far back as like when was your first filling? But we want to ask the patient, like, do you have any loose teeth, missing teeth, chipped or cracked teeth? Do you have any like mouth injuries or pain, or any like dental concerns that we should be aware of? If a patient has dentures, we don't want them to have their dentures in while they're getting surgery. So like that type of a dental history. It's definitely part of the pre-anesthesia assessment, but it doesn't have to be like all the way back to when they were a child, just like what their current concerns are. Good question.